சரி ஓகே. அப்ப சாப்பிட முடியாது. இல்ல கேண்டீன் தான் போகணும். கேண்டீன்ல தான் சாப்பாடு. அட்மிஷன் காட்டி அங்க போய் தான் பார்க்கணும். நேத்து மோர் குழம்பு, இன்னைக்கு என்னன்னு தெரியல. அங்க போய் பார்த்தா தான் தெரியும். சரி. மழை பெய்யுதுங்கம்மா. 2 3 நாளா மழை. 2 3 நாளா மழை. ஆ? நாளைக்கு நான் வந்துடுறேன். அப்ப மழை வரும் கூட. இங்க பா வேதாந்த். சரி. பாய். இல்ல இவர் இல்ல இவர் சார். நீங்க சார் அப்புறம் வந்துட்டு சார் நம்ம மெயில் நம்ம ஃபார்மேட்டா மெயில் பண்ணி சார் போஸ்ட் கொடுக்குறோம். சரில ரெக்கார்டிங் ஒரு ஸ்கூல்ல பேசியிருந்தாரு. இன்னைக்கு பேசிங்க சார் டேரக்டா. இது தேவையில்லைங்களா? டிஸ்கவுண்ட்லாம் எதுவுமே தேவை வேண்டாம். இது மைக் இதுலயே எடுத்துக்கலாம். இது மைக்கிங் சார். எடுத்துக்கும் அவங்க பேசும்போது தேவையில்லை. டிஸ்கவுண்ட்லாம் எதுவுமே தேவை. மைக் இதுலயே எடுத்துக்கலாம். இது மைக்கிங் சார். சார் உள்ள வந்துட்டீங்களா சார்? வாங்க சார் செக் பண்ணிக்கலாம் ஒன் பார்ட்டி ஆயிடுச்சு. நீங்க வந்து பவர் பாயிண்ட் கூட அப்புறம் சென்ட் பண்ணுங்க. அந்த மெயில் கூட வந்துருச்சு. ஓப்பன் தான் சார் இருக்கு. அதே லிங்க் தான் அப்படியே டச் பண்ணி வாங்கிக்கலாம் சார். சரி ஓகே. ஆமாம். ஹலோ. ஆமாம் சார் கூகுள் பே தான் சார். சார் கொஞ்சம் டவர் இருக்கிற இடத்துல வந்து போங்க சார். சார் நான் வரலைங்க சார் நீங்கள். வந்தாச்சுங்க சார். கோர்ஸ் கொடுக்குறேன் உங்கள் பவர் பாயிண்ட் போடுங்க சார்.
சொல்லுங்க சார்.
சார் உங்கள் பவர் பாயிண்ட் ஸ்லைட் சார் கொடுங்க சார்.
ஷேர் ஆப்ஷன் இல்ல
சார் கீழே அந்த சிம்பிள் இருக்கு பாருங்க சார். அந்த பிரசன்ட் நவுன்னு ஒரு சிம்பிள் இருக்குங்களா? சார் உங்க லேப்டாப்ல கீழே நிறைய ஆப்ஷன்ஸ் காட்டுது. ஃபிஃப்த் ஆப்ஷன் இருக்கு இல்லைங்களா சார்? அந்த ஏரோ சிம்பிள்.
ஷேர் ஸ்கிரீன் ஷேர்
ஷேர் ஸ்கிரீன் அதான் கொடுங்க.
இப்போ ஷேர்
இப்போ என்டையர் ஸ்கிரீன் கொடுங்க சார். என்டையர் ஸ்கிரீன் கொடுங்க. அதுல இக்னோர் கொடுத்து வந்துருச்சுன்னா அந்த ஹைட் கொடுங்க சார். ஹைட் டச் பண்ணுங்க. ஆமா சார். அப்புறம் ஃபுல் ஸ்கிரீன் தான்.
ஓகே வந்துருச்சு.
மாத்துங்க சார். அடுத்து மாத்துங்க. சேஞ்ச் பண்ணுங்க சார். ஓகே ஓகே சார். ஓகே வாய்ஸ் நல்லா கேக்குது சார்.
ஓகே
சார் 2 o'clock நாங்க இன்ட்ரோ கொடுப்போம் சார். நீங்க 2 to 2:03 ஸ்டார்ட் பண்ணிக்கலாம் சார்.
நான் கரெக்டா ஸ்டார்ட் பண்ணிடுறேன் சார்.
ஓகே சார். அடுத்த ஸ்லைட் போடுங்க சார். சார் நெக்ஸ்ட் ஸ்லைட் மாத்துங்க சார்.
மாத்திருக்கேன்.
இல்ல அடுத்து போங்க சார். போங்க.
ஃபோர்த் ஸ்லைட் வந்துருக்கு.
ஓகே மூவ் ஆகுது சார். நல்லா மூவ் ஆகுது. ஏதாவது ஹைப்பர் லிங்க் ஏதாவது போட்டிருக்கீங்களா சார்?
எதுவும் இல்லை சார்.
ஹைப்பர் லிங்க் இல்லைங்களா?
எதுவும் இல்லை.
சரிங்க சார். சரிங்க சார். சரி சார் நீங்க மியூட் பண்ணிட்டு அப்படியே இருங்க சார். நாங்க சொல்றோம்.
பிடிஎஃப் காமிக்கிறேன். இல்ல பிடிஎஃப் நான் இந்த விண்டோ ஸ்கிரீன்ல நான் காமிச்சிக்கிறேன் சார்.
அதை இது மினிமைஸ் பண்ணிட்டு அதை ஓபன் பண்ணிக்கோங்க சார்.
ஆமா. ஒரு 2 டூல் மட்டும் காமிக்கிறேன். நமக்கு ரொம்ப டைம் எடுக்க முடியாது. எல்லா டூலும் காமிக்கிறது.
சரிங்க சார். ஒரு 10 மினிட்ஸ்ங்க சார். ஸ்டார்ட் பண்ணிக்கலாம்.
வெயிட் பண்ணிக்கிறேன் சார். நோ ப்ராப்ளம்
சார். தேங்க்யூ சார்.
வெயிட் பண்ணிக்கப்பா.
அது ஸ்டார்ட் பண்ணி விட்டாச்சு. ஸ்டார்ட் பண்ணி விட்டாச்சு. இன்ஸ்டால் வரும்போது இப்படியே தான் இருக்கும். இமேஜ் மட்டும் வச்சோன்னு இங்க வந்து இங்கே ஸ்டாப் பண்ணணும். இது ஸ்டாப் பண்ணீங்கன்னா ஸ்டாப் கேட்கும். ஸ்டாப் பண்ணிக்கலாம். அதே மாதிரி அங்கே போயிட்டு இதை என்ட்ரி கொடுத்து இங்கே போயிட்டு இதை ஸ்டாப் பண்ணுங்க. ஓகே சார். மூணு பண்ணிக்கலாம். Okay. நான் பேசுனேன் சாயந்தரம் பேசுனேன் வந்துடுறாரு சார் ஸ்டார்ட் வாய்ஸ் கேட்குமா சார் 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 சார்
Good afternoon, everyone.
Good afternoon, sir. Good afternoon, everyone. A warm welcome to all the participants on the fifth day of our 10-day FDP. We appreciate your dedication and active participation throughout this journey. Today, we have the privilege of learning from an experienced educator and clinician, Mr. Selveshwaran, MPT Neuro, who is a professor at KMCH College of Physiotherapy. With 24 years of experience in the field, he has developed extensive expertise in functional movement analysis, constraint-induced movement therapy rehabilitation, coma stimulation. He has 3 publications and Dr. Radhakrishnan Award from SNS Institution. Now we are inviting Mr. Selveshwaran, Sir, MPT Neuro Professor, to lead today's session on quality of life assessment in neuro rehabilitation. Over to you, sir.
Thank you, Alexander, sir. Thank you. Good afternoon, everyone. So today, on the continuing faculty development program of KMCH College of Physiotherapy, we will discuss about the quality of life assessment in neuro rehabilitation. Before starting with the gratitude, I heartily thank our KMCH management authorities, our chairman, Sir Dr. Nalaji Palaniswamy, and our respected managing trustee, Dovmani Madam, Dovmani Palaniswamy Madam. Okay. And I sincerely thank our principal, Sir, Dr. S. Karthik Babu, and our vice principal, Madam, Mrs. A.P. Kalpana Madam, for giving me this opportunity to share my knowledge with our fellow physiotherapists. So, before going into, first of all, we discuss what is life. Okay. So, when you ask each and everyone, they will give their own ideas or their own perception. On their own perception, they will give their own definition or explanation to the term called life. According to Anais Nin, there is not one big cosmic meaning for all. There is only the meaning we each give to our own life, like an individual meaning, an individual plot, like an individual novel or book for each person. So each and every person is an individual book in this particular world concern. So, according to myself, when you ask what is life in the sense, I will say the life is an eternal one.
So sorry for the interruption. We didn't see your slides. Could you please share your slides, sir?
1 minute, sir. It's been shared, sir, actually.
Yeah, but we couldn't see, sir. Just you can wait for a second.
Is it visible now, sir?
No, sir. Not yet, sir.
The audience has mentioned us.
Actually, sir, in between it came, we had, now it is, now we are able to do. Please go for slideshow.
Okay.
Slideshow.
Yes, ma'am, opening. Sir, okay, ma'am?
Okay, sir. Yes, sir.
Okay, thank you everyone for the feedback. Yeah, so the life, and then what is quality of life when you take? According to the WHO, the quality of life is nothing but an individual's or a group of individuals' perception of his or her or their own position in life in the specific context or different contexts of the culture I would like to highlight. So now coming to what is the association between motor learning and the quality of life. So quality of life is a subjective phenomenon, some multidimensional concept that reflects an individual perception through his or her learning and as well as the experience concern, especially motor learning. The quality of life in the motor learning we have three stages like cognitive stage, associative stage and autonomous or automatic stage we say. In that the automatic stage where the skills are being developed to do over day-to-day life activities in a qualitative manner. Okay. Further say the, the quality comes the matter like. So we could say that there is a high level of strong association or correlation between our quality of life and our learning process to get a long-term memory process and experience. So if you ask anybody, so want to improve motor learning, what we could do, what the suggestions would come, so go for a proper and deep, adequate deep sleep, like that they may say. To emphasize the motor learning. It's like that we want to enjoy the life with optimal quality, learn the various aspects of life in broad spectrum so that you could get a good quality of life. Coming to the measures of quality of life. Okay. So these are the indicators used to assess the general well-being of the individuals, okay, and the societies. Once again, multiple societies. So each and every individual in their day-to-day life, they will face different societies. For an example, this particular FTP program, this is a part of society for a particular time being, we could say. Okay, or we are working in a hospital, this is just one part of society. Like that in our day-to-day life, what are all the how many number of the societies we come across? Each and every society, each and every person or human being is having its own quality of life and it could be measured by means of objective data based on the statistical data, objective measures, objective indicators, and of course according to the individual experience, how he or she or they experience like subjective, that is based on the personal perceptions. So now coming to the main topic, like how to measure the quality of life. So as I told previously, you have the objective measures. The indicators are number one, economic indicators, health indicators, education indicators, and environmental quality related indicators. Just like that, the subjective measures concern okay, self-reported happiness or the life satisfaction. Okay, how the individual feels like. Then the social support and relationships, freedom and human rights, safety and multiple dimensions of security in the society. Okay, it could be related to economics, or it could be related to the simple social security or legal related security, like that. Multiple dimensions of security, we could say. So what are the tools we are going to discuss? So when you take the neurological population or different categories of neuro patients concerned, there are a lot of quality of life assessment tools are there. Okay. But when we go on to that, the time will not be enough, so that I am coming to specifically to the stroke patients. Okay, among them, what are the very commonly used quality of life measurement tools? Okay, we'll go on with. Okay. These are all the list of tools like WHO QOL 100 questions. Okay, that's one thing. The WHO QOL brief, the brief form of the WHO QOL 100, and the third one is SF36, and the short version is SF12, the short form of health surveys. Then SIS, the stroke impact scale, and the SSQOL, the stroke specific quality of life scale. These are the tools we are going to discuss. Now coming to the first scale, WHO QOL 100. Okay, so it's designed by the WHO. Okay, it consists of 100 questions with 6 broad domains, each domains with multiple subdomains also. And of course, every individual questioner being assessed with a 5-point Likert scale. It starts from one score will be given 1 for very much dissatisfied, 1 and the score 5 for very much satisfied. So the approximate time to complete for a patient to complete this particular WHO questionnaire, okay, 20 to 30 minutes. And the utility and usage concern used in clinical researches, public health sectors, and in our rehabilitation process concern. So what are those 6 domains when you take physical health and the subdomains in that is being displayed? Okay. Physical health, energy and fatigue, I think I'm not going to read. Okay. So the physical health aspects, then the mental or psychological aspects. So actually in that we are supposed to go on in somewhat in a detailed way. Like psychological, we have our emotional aspects, social aspects, intellectual aspects. Okay, in that the main one of the main thing we considered in the stroke patients concern, the middle one called the self-esteem. It's having its own impact. Like the third one, level of independence, and that the mobility, the ideal, the dependence on the substances, work capacity. The fourth, fifth, and sixth one have been represented here. Social relationships, environment, it's not simply environment, multiple environments move on the quality of life of a patient. Okay, concern. Then coming to the last one, spirituality, religion, and personal beliefs concern. Because each and every one's personal beliefs might be varying. Okay. So according to that particular person's beliefs, okay, the questionnaires will be asked and the answers will be evaluated. So coming to the psychometric properties of this particular specific tool, the acceptable internal consistency, okay, converts alpha value is around 0.76 to 0.90 across almost all the domains concerned. And in the study, okay, done by Linjeng et al. Okay, in the journal being published, World Health Organization, during the year July 2004, the study proved that there is a strong correlation between the domains of WHO 100 and the dimensions, those six domains, dimensions of the general quality of life inventory, another inventory concern. So for that, the concurrent validity also they mentioned like it is around 0.72 to 0.82 across all related domains concerned. So coming to the strengths and the limitations of the specific tool concerned. Coming to the strengths, this particular tool, as it is being designed by the World Health Organization, it is being used or utilized by the clinical areas of all over the world. Okay. Why? Because in the sense it's quite highly comprehensive, multidimensional with 100 questions once again, and of course validated internationally by the many researchers, including in our own country, okay, in different languages like Hindi, Tamil, Telugu, Bengali, and of course many other languages too. It captures culture-specific and value-based perceptions of well-being, also being considered as a very good strength for this particular assessment tool. So then coming to the limitations, wherever the positive things are there, there will be some sort of negatives also will be there, right? So we are supposed to bother all such things before we select our tool for doing our research or to identify the prognosis of the outcomes of our interventions being given to our patients, certainly. So what are the limitations of this particular tool? Number one, the name, the number of questions itself, we could say it's quite lengthy. 100 questions, 100 questions எப்படிங்க கேட்க முடியும்? அது ஒரு ஸ்ட்ரோக் பேஷன்ஸ்க்கு அது எப்படி பொறுமையா பதில் சொல்லுவாங்க? நம்ம ஊர்ல ரொம்ப ஈஸியாவே கேட்பாங்க. But there comes our patients first of all. We should have our own patients and we should make the patient to be patient. That's why the patient is being called so. அவங்களை பொறுமையா ஆக்கணும், பொறுமையா அதை வந்து டீல் பண்ணி அவங்களோட ஒப்பீனியனை கேட்டு அவங்களோட ஆன்சர்ஸை கேட்டு ப்ராப்பரா கால்குலேட் பண்ணி அவங்களோட குவாலிட்டி ஆஃப் லைஃப் எந்த அளவுக்கு இருக்குன்றத ஐடென்டிஃபை பண்றது தான் நம்மளோட டேலண்ட் அண்ட் எக்ஸ்பீரியன்ஸ் கன்சர்ன். So lengthy one, that is one of the high limitations concerned, so that the physiotherapist okay, but often, very often, the two, the what is it, very ill or chronic patients concerned who are highly depressed or who are having high level of stress and all, post-stroke stress and all. Okay. On one side, when you take chronic patients, the other side, very acute patients also, they will not be that much, what is it, ideal enough to undergo this particular questionnaire. Most of the quality of life assessment questionnaires will not be implementable in the very acute stage, actually, practically speaking. To the possible extent, we could assess, and once a patient has become readily enough, we could implement the tool to a satisfactory extent, and we could try to get the valid results or outcomes. Okay. Another limitation, so the other version is called WHO brief, BREF actually, which is having a 26 item, a short version of the WHO 100 concern. This is often preferred in clinical settings for stroke patients to use. But one of the thing is, it's not only for the stroke patients concerned, but any geriatric population, we can use this particular tool. Okay. So coming to the second tool, WQOL RIF. Okay, it's a comparatively quicker one. It requires more reliable and cross-culturally valid assessment of the quality of life among the stroke patients and any geriatric population. That's the thing being highlighted in the bracket line. Okay, so more applicable for any general geriatric population, so that we could apply for somewhat of very stable stroke patients too. So the name itself, it's like 26 questions are there in this particular questionnaire. In the format of self-administered or interview-based questions, the approximate time to complete this particular questionnaire is around 10 to 15 minutes. And here also the same type of 5-point Likert scale is a scoring method. So coming to the psychometric properties of this particular tool, the WQOL RIF. Adequate internal consistency Cronbus alpha from 0.64 to 0.90 have been got from multiple researchers, especially this result have been given by the Margatia Ghosh et al. In the journal being published Health Quality of Life Outcomes during the year 2021. So in that, Cronbus, see, when you take any tool, so number one is validity, two, the reliability. In that, the multiple the types you have. So in that, I will say like the test retest reliability, concurrent validity. Then the other one, very important one, in quality of life concern, context validity is one of the very important. Like context validity is very important. Okay, why I'm highlighting that in the sense, especially in our country, when you take this particular questionnaire in English version, okay, or which consists of the previous tool and which is having 100 questions, which could be implementable for almost like some sort of high middle class family could be implementable. But when you take a very poor family persons and all, we could not apply. So one of the barrier or the limitation is coming is the economical status of the individual patient and patient family members concerned. Okay, so when you don't bother about that, the quality of life will not be assessed in a proper way, which means that either the validity will be problematic or the reliability might be a very big issue. So all these properties of a specific tool we would like to use in our own patients concern, we are supposed to consider to a greater extent. Okay, that apart from that, reliability and validity concern, one more main thing is the internal consistency. Okay, so that is also being calculated by the Cronbus alpha. There is a very much important one. So here 0.64 to 0.90 the range concern. Then the composite reliability values ranges from 0.59 to 0.88, and the conversion validity is quite tolerable. The average variance extracted from 0.374 to 0.614. Okay. So coming to the strengths and limitations of this particular tool, WQOL RIF concern. Okay, the strengths. So it is used in the Indian studies in the various hospitals, including AAMS, PJMER, demands high level of psychiatric illness and psychological different categories of psychologically ill patients are being assessed with a specific tool. The other one is the tool is validated with multiple Indian language versions which are available for both research purposes and as well as clinical utility. So here the question may come for some sort of initial researchers or initial clinical practitioners concern. Sir, என்ன சார் ரிசர்ச்க்கு தனியா ஒரு டூல் இல்ல கிளினிக்கல் யூட்டிலிட்டிக்கு தனியா ஒரு டூல் வேணுமா சார் அப்படின்னு கேட்டா, ஸோ சர்டன்லி தனித்தனியா டூல்ன்றது இல்ல, a common tool which is being generalizable, okay, for the research purpose and as well as clinical purpose அப்படின்ற மாதிரி அந்த டூல் வந்து டிசைன் ஆயிருந்தது அப்படின்னா, that is having a very good strength and its utility, practicality and practical utility concern. Okay, இதுக்கு தனியா அதுக்கு தனியான்ற மாதிரி இருந்தா நாட் practically implementable concern. பட் தனித்தனியா இருக்கலாம், அது தப்பு இல்லை. பட் ரெண்டுக்குமே implementable இருந்ததுன்னா that tool is that assessment measure is a very better one, we could say. So and it can be adopted for face-to-face interviews for illiterate or disabled patients concerned. So the educational status, the disability level, and the other thing I would told, the economical burden, okay, all those things will be according to that could be adopted. So one of the strength concerns. Coming to the limitations concern, so comparing to the previous one, okay, in this particular tool there is less detailed aspects of the patient only could be got. Okay. And some stroke specific concerns like communication issues, cognitive deficiencies cannot be fully addressed, and most of the things are being focused more towards the physical and mental aspects only. So, and it can be complemented with the tools like the SSQOL or stroke impact scale concern. So, once again, according to the specific references I have mentioned. Coming to the very next tool called SF36 and its short form called SF12. Okay. So actually SF itself a short form only. So the short form 36 survey is a health survey, and short form 12 items another survey. Okay. According to the practicality you could utilize. So the SF36 and as well as SF12 are general health related quality of life questionnaires. So for quality of life questionnaire அப்படின்னு சொல்றதை விட நம்மளோட பேஷன்ஸ் போகும்போது specific terminology or specific type of tool called the methods called HRQOL, health related quality of life assessment questionnaire. Okay. எப்பயுமே அந்த கீவேர்ட்ஸ்ல வந்து நம்ம ரிசர்ச் பண்றதுனாலும் சரி, இல்ல நம்மளோட பேஷண்ட்டுக்கான அசஸ்மெண்ட் நம்ம கிளினிக்கல் ட்ரீட்மெண்ட்னாலும் சரி, நம்ம ஒரு அசஸ்மெண்ட் டூல் செலக்ட் பண்ண போறோம் அப்படின்னா better to select a tool called tool version called HRQOL அப்படிங்கிற மாதிரியான டூலை செலக்ட் பண்ணிட்டோம்னா நம்ம அந்த அசஸ்மெண்ட் வந்து நல்லா பெட்டரான சைக்கோமெட்ரிக் ப்ராப்பர்ட்டிஸ் கூட நமக்கு கிடைக்கும் சொல்லலாம். And of course, in a better way, we could assess the patient's concern. Okay. So HRQOL question is designed to assess the overall well-being from the patient's perspective concern. So what about the SF36 short form 36 concern consists of 36 questions with 8 domains concern. The previous இதில் பார்த்தோம்னா 6 domains பார்த்தோம். இங்க வந்து பாத்தீங்கன்னா 8 domains, 8 health domains they are mentioned. Like what are all those? So physical functioning, physical ability, here pain, bodily pain, general health, vitality, social functioning, the emotional role, of course, mental health specifically being measured in the 8 items concerned, 8 domains concerned. So here also the psychometric properties when you see the test retest reliability, there is combined ICC at the highest value in domains like social functioning have been got up to 0.80 and general health 0.79. Bodily pain is 0.75 identified among the chronic stroke patients by a study conducted by the Derman et al. In 1998 itself. And inter-rater reliability of 0.89 and intra-rater reliability of 0.83 to 0.93 have been got the study done among chronic stroke patients by Cabral et al. An adequate level of adequate to excellent level of internal consistency, the compass alpha value. So it's more than 0.70. In the sense, not less than 0.70. That's meaning like clear. 70 la adha romba adhigam over study la oru maadhiri vandirukra maadhiri they are revealing like more than 0.70 was identified study done by Hagen et al. Specifically the year 2003 being done. But when you go into the different databases, okay, the particular tool there are a lot of practical, a lot of researches have been done by utilizing this particular tool with high level of higher level of internal consistency values. And the other important factor, the psychometric properties of convergent validity of SF36 by the related, that is SF36 of Brazilian version, okay, and the Nottingham Health profile spearmint, okay, health profile, okay, அதில் இந்த ரெண்டு டூலோட கன்வர்ஜன் வேலிடிட்டி பார்க்கும்போது the spearmint row value, okay, rank correlation value எவ்வளவு வந்திருக்குன்னு கேட்டீங்கன்னா 0.80 was identified by the person Anderson et al. During the year 1996. Okay. So coming to the strengths and limitations of this particular tool, it's widely validated internationally, okay, and as well as in our own country. It allows comparison across the diseases, different diseases, especially the stroke concern. Stroke the main disease and so not suitable for the rehabilitation studies in the stroke specifically. The limitations concern longer to complete but according to me, it's not that much time. So it's approximately 10 to 15 minutes it takes. Okay. So 36 items in போகும்போது அதுல 8 domains நம்ம பார்க்கும்போது minimum 10 to 15 minutes எடுக்க தான் செய்யும். Okay. So அப்போ முடிஞ்ச அளவுக்கு அந்த ஒரு ஆப்டிமல் டைம் நம்ம ஸ்பெண்ட் பண்ணாதான் எக்ஸாக்டா நம்மளால வேலிடா நம்மளால பேஷண்டோட அந்த பர்டிகுலர் ஸ்பெசிபிக் பேஷண்டோட அந்த பர்டிகுலர் டைம்ல அந்த ஸ்டேஜ்ல அவரோட quality of life எவ்வளவு இருக்கு அப்படிங்கறத நம்மளால calculate பண்ண முடியும். Okay. The other limitation they have highlighted here is the non-stroke specific. Okay, that is miss the stroke related issues like communication deficits or the limb dominance. Okay, that is what about the dominant hemisphere involvement or non-dominant hemisphere involvement where we give the limitations called what is it? More affected side, less affected side. அப்படிலாம் பார்க்கும்போது any sort of quality of life assessment tool is supposed to be designed for the whole body, not for the affected side alone or the what is it? Normal side நம்ம சொல்றோம் the less affected side alone. Okay, so it's meaningless. Okay, for the whole body it is supposed to be. Okay. So coming to the short form of the SF short form of SF36 is SF12. Okay, it's having the name itself here instead of 36 is here 12 questions. Okay, so the scoring gives the two summary scores, mainly the physical component summary PCS, the mental component summary or MCS, being considered and designed for the faster screening, especially in the somewhat in the very subacute stages of the stroke patients concerned. And it is being apparently satisfactory to good levels of the internal consistency value 0.74 to 0.91. Okay, here also the high level values only and was identified in a study done by CT Baum et al. Year, the recent year 2023. So for the strengths and limitations here, okay, and 15 minutes and mention the duration concerns here will take around 2 to 5 minutes only and retains a 90% of SF36 predictive power. Okay, so it is possible. Only thing is the expertism is very important. Okay, then it is suitable for the larger studies or when the time is being limited for a specific study to be done in a short period of time. What to say, restrictive factor நமக்கு இருக்கு அந்த particular assessment பண்றதுக்கு அப்படிங்கிற டைம்ல எல்லாம் better to go for SF12 or into SF36. Coming to the limitations concerned, okay, so ஒரு பக்கம் பாசிட்டிவ்னா less detailed இருக்கு lessons for the individual domains to more extent, more detailed way, and we miss the subtle changes in the specific aspects of the quality of life. Okay, in stroke recovery concern, recovery, that is the outcome of prognosis அப்படின்னு வரும்போது இதுல ஒரு சில ஐட்டம்ஸ் வந்து மிஸ் ஆகுதுன்றது ஹைலைட் பண்ணிருக்கிறேன். Coming to the very next tool is SIS, the stroke impact scale. So SIS 3.0 has around 59 items organized into 8 domains here. So there is 8 domains plus okay, global recovery rating also being considered actually. Okay, so the time to complete this particular tool is taking around 15 to 20 minutes. Okay, and of course this is also a self-report or interview administered format concern. Okay. So most of the tools are definition subjective, but not only subjective and as well as objective are supposed to objective indicators are supposed to be considered in a quality of life measurement concern. So here also a 5-point Likert scale is being used to calculate the total scores, individual scores and total scores. 1 represents extreme difficulty and 5 represents there is no difficulty. The domains, what are those 8 domains concerned? The strength and function, ADL, there is ADL, IADL, then mobility, communication, inclusion, memory and thinking, social participation. So almost like all the aspects of those what to say, aspects of the quality of life or different dimensions and domains of life of a patient have been included in this particular assessment tool or outcome measure. So I think I wanted to tell the description of the individual domain concern. So coming to the psychometric properties of this SIS. So one of the research, okay, the test retest reliability, there is intra-class correlation coefficient is around 0.88 with the 95% of confidence interval in the 0.75 to 0.94. So also a considerable one, and that is coming to a reliability concern. What about the concurrent validity with the SF-SIS score with the stroke impact score? SF-SIS with SIS 2.0. Okay, this is the previous version. இது வந்து 3.0. Coming to the 2.0, அது இந்த ரெண்டு டூலுக்கான concurrent validity பார்க்கும்போது the row value had come around 0.90. Okay, as well as the EQ5D5L. This is also one of the very important and sensitive parameter to be considered by the physiotherapist. Specifically, I would like to highlight here. Okay, the row value is around 0.79. So high, and this is also very high value. This study done by Anna Corpus HR in Health Quality of Life Outcomes Journal during the year 2021. Okay, coming to the next one, that is an excellent internal consistency at all time points, that is Cronbach values more than 0.81, okay, which composes the physical functioning score especially, because excellent at all time points. Okay, அதுலயும் internal consistency எல்லாத்துலயுமே எல்லா டொமைன்ஸ்லயும் இருக்குன்னு சொல்லியிருக்காங்க. அது எஸ்பெஷலி the physical functioning scoreல வந்து the range is going more than 0.95 only. So among the subacute stroke subjects by the study done by Richardson et al. During the year 2016. So what about the strengths and limitations of this particular tool? So strengths, so quite comprehensive. High level of the spectrum has been covered. So comprehensive stroke specific quality of life assessment, and is focused on the real life function and as well as the active participation of the patient in the society. And it is different, have different contexts, different environments, okay, that could be assessed. And it's useful for the goal setting in the the long term, the acute care and as well as the long term stroke rehabilitation process. இந்த tool தான் ரொம்ப ரொம்ப காமனா யூஸ் பண்ற ஒரு டூல்னு சொல்லலாம். Of course it's easy to use even in the home setup or community based physiotherapy settings. Okay, coming to the limitations, may be challenging for the patients with severe aphasia. So the limitation எடுத்தீங்கன்னா quality of life assessment பார்க்கும்போது subjective நம்ம சொல்றோம். So very immediate question, very early learners they used to ask to myself at all during the postings or in the theory classes. The students used to ask these learners, sir aphasia இருக்கும்போது இல்ல dysphasia இருக்கும்போது எப்படி சார் நம்ம இந்த சப்ஜெக்டிவ் கொஸ்டினர்ஸ் அது குவாலிட்டி ஆஃப் லைஃப்ன்றதெல்லாம் எப்படி சார் நம்மளால அசஸ் பண்ண முடியும், அவங்களால பேசவே முடியாது, பேசுறது கஷ்டமா இருக்குமே அப்படின்னு கொஸ்டின் கேட்பாங்க. Clever questions only. Okay, so here what is it? By means of the other modes of communications we are supposed to use. அப்படி இல்ல கட்டரைக்கோடு வந்ததுக்கு அப்புறம் தான் most of the time quality of life assessment right நமக்கு வரும். When there is a strong need in the sense we are supposed to go for the other means of communications, like you can ask a question and we could ask the patient to write the answer or pick the answer, giving the questionnaire to the patient. Okay, அதை வந்து நம்ம ரீட் பண்ணி காமிச்சிட்டு we could get the support or help from the primary caregiver of the patient. Okay, so அப்போ வந்து ரொம்ப அந்த லிமிடேஷன் நம்மளால ஓவர்கம் பண்ண முடியும். Not only this SIS, any quality of life assessment questionnaire or survey concern. So the cognitive impairments also. So the interviewer administrative person can be very much helpful to overcome these limitations. Another limitation is slightly longer than the general ones like EQ5D or SF12 concern. So coming to the stroke specific quality of life scale, the tool SSQOL. Okay, so it is a quite comprehensive and stroke specific. Specifically designed for the stroke only. Okay, instrument developed to measure the health related, once again HRQOL, that is one of the health related quality of life of stroke patients, stroke survivors. So across the multiple domains, okay, being assessed. So it provides a patient-centered view of the recovery with a special focus on the functional limitations, especially then the emotional well-being and as well as the social involvement, social participation concern. Okay, what are the items? The number of items are 49. Domains are 12 functional and as well as psychosocial domains. Okay. So the format as usual, like self-reported or reported or the interviewer administered format you could go on. Here also a 5-point Likert scale being used where score 1 represents the worst outcome or the total difficulty or maximum difficulty or highly dissatisfied or all the patient is fully satisfied with this life being maintained or being going on. The approximate time to complete this particular tool administered will be taking approximately 15 to 20 minutes. So what about the domains concerned? All domains we don't know. So number 1 is energy, family roles, language, mobility, mood, personality, self-care, social roles, thinking, upper extremity functions and visions, visual ability, and of course the work or the job related or work and the productivity related questions will be there. Domains, that particular usual domains concerned. So here, as far as psychometric property is concerned, there is an acceptable test-retest reliability for all SSQOL domains. Total SSQOL is around ICC more than 0.70 has been identified, and excellent test reliability, okay, ICS value more than 0.90, okay, especially for the energy, the family role, the long wage, self-care, upper extremity function, and the visual function domains, especially. So, the study done among the stroke patients by Dr. Salam Chal during the year 2019. What about the advantages and limitations of this particular assessment tool concern? Okay, the advantages, as we are told, the name itself, it's being designed for the stroke patients only, so that it is stroke specific, it is holistic fact. Okay, any particular stage of the stroke patients, we could replace this particular tool. It is validated internationally and as well as in our own country in different type of contexts concerned. The context validity is quite agencies. And it covers physical aspects, emotional aspects, and as well as social aspects concerned. In other, like what to say, physical, psychological, psychological intellectual aspect, emotional aspect, there is the physical ability of the patient, okay, intellectual problem solving ability. For example, if we take the intellectual ability, emotional viability, uh, emotional stability, and social viability, all those things are being covered by assessed in this particular tool concept. Okay, and it's more sensitive to the changes in the stroke, so its prognosis or the outcome or the recovery than the other tools like SF36 or WQOL, QOL, or WQOL BREF comparatively. The limitations concerned, as being mentioned, the other longer tools, 49 items being considered as one of the limitations. Okay, and patients with aphasia, severe cognitive deficits may need some sort of assistance to complete the scale by the patient. Okay, or very acute stage, apply for here. Okay, so when you go for the quality of life assessment being done by physiotherapists concerned, okay, we are supposed to be very, very, very careful, and we are supposed to be very much skillful. Okay, skillful to deal with the tool concern. ஒரு டூல் எடுக்கிறோம், ஒரு அசஸ்மெண்ட் டூல் அவுட்கம் மெஷர் எடுக்கிறோம்னா அதை பத்தின டீடைல் ஹிஸ்டரி, ஓகே, அதோட யூட்டிலிட்டி, அதோட சைக்கோமெட்ரிக் ப்ராப்பர்ட்டிஸ், ஓகே, நம்ம செலக்ட் பண்ணி நமக்கு நம்ம அசஸ் பண்ண போற பேஷண்ட்டுக்கு அது எந்த அளவுக்கு அப்ராப்ரியேட், தட் இஸ் வேலிடிட்டி ஃபார் தட் பர்டிகுலர் ஸ்பெசிபிக் பேஷண்ட் ஆர் த ஸ்டடி பாப்புலேஷன். ஒரு ரிசர்ச் பண்ண போறோம்னா அந்த பர்டிகுலர் ஸ்டடி பாப்புலேஷன் எந்த அளவுக்கு அது வேலிடா இருக்கு அப்படிங்கறது எல்லாமே டீடைலா நம்ம கன்ஃபார்ம் பண்ணதுக்கு அப்புறம் தான். ஃபார் எக்ஸாம்பிள், பை மீன்ஸ் ஆஃப் pilot study, by means of a pilot study, should confirm the reliability, validity, internal consistency, and of course all other parameters to the possible extent. இதெல்லாம் பண்ணதுக்கு அப்புறம் தான் நம்ம அதை செலக்ட் பண்ணணும், அதை இம்ப்ளிமெண்ட் பண்ணணும். ஓகே, சர்டன்லி. And of course high level of limitations இருக்கு அப்படின்னா அப்போ what will be the alternative tool, alternative choice, okay, அப்படிங்கிறதுலயும் நம்ம அந்த செலெக்ஷன் ப்ராசஸ், the sense the decision making process by means by a physiotherapist, this physiotherapy decision making process. ஓகே, அங்க இன்டர்வென்ஷன்ஸ்ல இருக்கிறதுன்றது என்ன கேட்டா செகண்டரி தான் நான் சொல்லுவேன். ஓகே, the primary one is we are supposed to be very much skillful in the assessment skills. ஓகே, assessment skillsல என்ன மாதிரியான அசஸ்மெண்ட் டூல்ஸ் நம்ம யூஸ் பண்றோம், அதுலயும் மெயினா அந்த மாதிரி குவாலிட்டி ஆஃப் லைஃப் வரும்போது அந்த பர்டிகுலர் ரைட்டா அசஸ் பண்றதுக்கு என்ன டூல் யூஸ் பண்றோம் அப்படிங்கிற அந்த decision making process to select an appropriate tool for that particular population is very, very important. Okay, அது தெரிஞ்சுக்கணும்னா அதுக்கு ஏற்ற மாதிரி நம்ம அதிகமா ஸ்கில்டாவும் நிறைய விஷயங்கள் அதை பத்தி நிறைய லேர்னிங் நாலேஜ் we should gain, okay, to reach to the level of, once again, third stage of learning we are supposed to go for, and so that we could make it. Up here, the message to be, the take home message of this particular presentation in my aspect concern, the message to be encoded in our long term memory. அப்படி நான் கேட்டேன்னா, இந்த மாதிரி ஒரு கொஸ்டின் உங்ககிட்ட கேட்டேன்னா நீங்க என்ன பதில் சொல்லுவீங்க? சார், ஏதோ ஒரு 5-6 டூல் பத்தி சொன்னீங்க, அதை பத்தின ஒரு சைக்கோமெட்ரிக் ப்ராப்பர்ட்டிஸ் சொன்னீங்க, அதுல எத்தனை கொஸ்டின்ஸ் இருக்குன்னு சொன்னீங்க, பட் அது லிமிடேஷன்ஸ் அண்ட் அட்வான்டேஜஸ் சொன்னீங்க, ஏதோ சிம்பிளா இருக்கு சார் அப்படின்னு ஒரு சிலர் சொல்லலாம். இதே ஒரு சிலருக்கு பார்த்தா இதுவரைக்கும் கேள்விப்படாத விஷயமா இருக்கு, அப்ப இன்னும் நிறைய டூல்ஸ் எல்லாம் இருக்குன்னு சொல்றாரு, அப்ப அதெல்லாம் பத்தி இன்னும் நிறைய தெரிஞ்சுக்கணுமோ, நம்ம ஒரு ஒண்ணு தெரிஞ்சுக்காம இருக்கிறோமோ அப்படின்னு ஒரு சிலர் நினைக்கலாம். ஓகே, so நம்மளோட இண்டிவிஜுவல் பெர்செப்ஷன் will be varying towards my class. இப்போ என்னோட கிளாஸ் பத்தின ஃபீட்பேக் நான் உங்ககிட்ட கேட்கிறேன் அப்படின்னா, ஓகே, ஸோ இண்டிவிஜுவல் பெர்செப்ஷன் அப்படின்னு வந்துட்டீங்கனாலே இண்டிவிஜுவலிட்டி ஒன்லி, Okay. எப்படி நம்ம சர்ச்ங்கிறத ரீசர்ச்ன்ற மாதிரி நம்ம மென்ஷன் பண்றோம். சர்ச் again and again is nothing but research. அது மாதிரி individual only. Whenever we assess, we should consider அந்த இண்டிவிஜுவலுக்கு நம்ம அசஸ் பண்றது பெர்ஃபெக்ட்டா இருக்கா, அக்யூரேட்டா இருக்கா அப்படிங்கிறதுல மேக்ஸிமம் சாட்டிஸ்ஃபேக்ஷன் ஒரு பிசியோதெரபிஸ்ட் இருந்ததுன்னா certainly that individual physiotherapist could prove himself or herself to the society. Assessmentலயே ஸ்பெசிபிக் சென்சிட்டிவிட்டி ஆர் வாட் இஸ் இட் அந்த அளவுக்கு ஸ்பெசிபிக் அட்டென்ஷன் அண்ட் ஆக்டிவ் பார்ட்டிசிபேஷன் பேஷன்ஸோட டீல் பண்ணாருன்னா நிச்சயமா அந்த பிசியோதெரபிஸ்ட் அவுட்கம் மெசர் அவுட்கம் இன்டர்வென்ஷன்ஸ் கொடுக்கறதுலையும் ட்ரீட்மெண்ட் ப்ரோட்டோகால்ஸ் டிசைன் பண்றதுலையுமே நிச்சயமா ஸ்கில்டா இருப்பாரு. அந்த சொசைட்டிக்கு அந்த பிசியோதெரபிஸ்ட் நிச்சயமா நம்ம ஃபீல்ட பத்தின எஃபிகசி, the role of physiotherapist in different clinical populations, different geographical areas, okay, that we could prove, okay, to a great extent, certainly, okay, after the arrival of our Guru Council India, KMCH, okay, certainly we could prove by working in a dedicated way, okay, with a high level of unity among ourselves throughout the country. Okay, so as usual quotation in my class, I could say, learn பண்ணிக்கிட்டோம் அப்படின்னா சூப்பரா படிச்சிட்டாங்க, நிறைய படிச்சிட்டாங்க, 100 மார்க் வாங்க போறாங்க, 95 மார்க்ஸ் வாங்க போறாங்க அப்படின்னு சொல்றதெல்லாம் somewhat once again it's subjective only. அந்த இண்டிவிஜுவலோட அந்த டைமிங் to go before we sleep. Okay, so that's my conclusion. Any sort of questions or doubts to be clarified in the sense, I request the FDP conducting authority to unmute the specific participant to interact with me. Thank you everyone for the quite important patient way of listening to me. Yes sir, yes madam.
Sir, எனக்கு ஒரு டவுட் இருக்கு சார். ஆக்சுவலா
Yes sir.
சார் டவுட் என்னன்னா, நம்ம கிளினிக்கல் ஸ்கேலுக்கும் நம்ம ரிசர்ச்க்கு யூஸ் பண்ற ஸ்கேல்ஸும் ரியாலிட்டியில அவுட்கம்ஸ் எப்படி சார் ஐடியா?
இப்போ நான் மென்ஷன் பண்ண இந்த டூல்ஸ் எல்லாமே ஆல்மோஸ்ட் ரெண்டு டொமைன்லயும், ரெண்டு கண்டெக்ஸ்ட்லயும் கிளினிக்கல் என்வரான்மெண்ட்லயும் நம்ம அசஸ் பண்ணலாம் சார். அதே டயத்துல we could utilize in the research areas also. பெருசா நமக்கு டிஃபரன்ஸ் இல்ல. ரொம்ப சென்சிட்டிவா சொல்ல போனோம் அப்படின்னா what is our aim? இப்போ நீங்க டூல நீங்க யூஸ் பண்றீங்கன்னா what is your aim? நீங்களே சொல்றீங்க, ஒரு பேஷண்ட் ட்ரீட் பண்ண போறோம் அப்படின்னா your main aim என்னது? அந்த பேஷண்ட்டுக்கு இந்த டூல வச்சு யூட்டிலைஸ் பண்ணும்போது அவரோட ஃபுல் ப்ராப்ளம்ஸையும் மேக்ஸிமம் ஆஃப் ப்ராப்ளம்ஸ் நம்மளால ஐடென்டிஃபை பண்ண முடியுதா அப்படிங்கிற அந்த கொஸ்டினுக்கு அந்த டூல் ஃபுல் ஆன்சர் கொடுக்குதா, அந்த ஃபுல் ஏரியாஸையும் கவர் பண்ணுதா? ஃபார் எக்ஸாம்பிள் நான் சொல்றேன், ஒரு எக்கனாமிக் ஸ்டேட்டஸ் பிரகாரம் நீங்க டீல் பண்றது ஒரு பூர் பேஷண்ட். அந்த பூர் பேஷண்ட்னா பூர் பேஷண்ட்டுக்கு அவரோட குவாலிட்டி ஆஃப் லைஃப், அவர் வந்து சாப்பிடுற சாப்பாடுல இருந்து, அவர் போடுற செப்பல்ல இருந்து, அவர் இருக்கிற வீடு, லிவிங் என்வரான்மெண்ட் அப்படிங்கிறது எல்லாத்துலயுமே வந்து வேரியேஷன்ஸ் வரும். அப்போ அதெல்லாம் கவர் பண்ணுதா அந்த பேஷண்டோட அவுட்கம் பாக்குறதுக்கு, இல்ல அந்த பேஷண்ட் கொடுக்குற ட்ரீட்மெண்ட் வந்து பெட்டரா இருக்கா அப்படிங்கிற ப்ரோக்னோசிஸ பாக்குறதுக்கு, அப்படிங்கிற பாயிண்ட் ஆஃப் வியூல அந்த டூல் இருந்தது அப்படின்னா ரிகமெண்ட்ஸ் பாத்தீங்கன்னா அதுக்கேற்ற மாதிரி நம்ம செலக்ட் பண்ணலாம்.
சார் இப்போ மிக்ஸ்ட் பாப்புலேஷன் அப்ப என்ன சார் பண்றது? ஃபார் எக்ஸாம்பிள்
இப்ப நான் சொல்லிருக்க இந்த இப்ப நீங்க மென்ஷன் பண்ணிருக்க எல்லா டூல்ஸுமே மிக்ஸ்ட் பாப்புலேஷன்ஸ் புரியுது சார்.
ஓகே,
lot of tools are there. உள்ள சர்ச் இன்ஜின்ல டிஃபரண்ட் டேட்டாபேसेस இல்ல டிஃபரண்ட் ரிசர்ச் ஜர்னல்ஸ்ல நீங்க போய் பாத்தீங்கன்னா once again ஸ்ட்ரோக்கு கூடிய பேர் டூல்ஸ் மட்டும் தான் நான் மென்ஷன் பண்ணிருக்கேன். So when you go for your other populations, other clinical populations of multiple sclerosis, okay, or நேத்து நம்ம மேடம் டிஸ்கஸ் பண்ண பார்க்கின்சன்ஸ் டிசீஸ், or GBS, இந்த மாதிரி டிஃபரண்ட் கிளினிக்கல் பாப்புலேஷன்ஸ் போனீங்கன்னா அந்த பேஷண்ட்க்கு ஏத்த மாதிரியான appropriate what to say, the quality of life measures or measuring tools are available. ஏன்னா நமக்கு நம்ம பெருசா பெரிய அளவுக்கு தெரிஞ்சுக்காம இருக்குன்றதுதான் உண்மை. அப்போ நம்ம கரெக்டா நம்ம ஃபுல்லா டீடைலா தெரிஞ்சுக்கிட்டோம்னா அதுக்கேற்ற மாதிரி we could select it and we could apply it and we could get our maximum success.
சார் இப்போ WHO QOL இருக்குல்ல 100 ரைட்ஸ், அதுல வந்து நம்ம வந்து மாடிஃபை பண்ணி நம்ம நியூ டூல் இன்வென்ட் பண்ண முடியுமா? ஏதாவது பாசிபிலிட்டிஸ் இருக்கா? சேம் அகைன் நம்ம இன்டர்நேஷனல் ஸ்கேல் டெஸ்ட் பத்தி கோஎஃபிஷியன்ட் எல்லாம் கொண்டு வராங்க.
நிச்சயமா வந்து இட்ஸ் நாட் அன் ஈஸி டாஸ்க் சார். ஏன்னா அது WHO டிசைன் பண்ணிருக்கிற ஒரு டூல் ரிலேட்டட் குவாலிட்டி ஆஃப் லைஃப். நிச்சயமா வந்து எல்லா ஜியோகிராபிக்கல் ஏரியாவும் கவர் பண்ற மாதிரியான கொஸ்டின் தான் மென்ஷன் பண்ணிருப்பாங்க. அதை நம்ம ஒரு ஸ்பெசிபிக் டொமைன் ஸ்பெசிபிக் கண்டெக்ஸ்ட், இப்ப நம்ம தமிழ்நாடு மட்டும் அப்ளிகபிளா இருக்கிற மாதிரியான டூலை அதை நான் மாத்த போறேன், இல்ல நம்மளோட கண்ட்ரி இந்தியாவுக்கு தேவையான மாதிரி அதை நான் மாடிஃபை பண்ண போறேன் அப்படின்ற மாதிரி உங்களோட எய்ம் இருக்கு அப்படின்னா, so first of all fix that one. According to that you are supposed to get number one proper permission. அவங்களுக்கு வந்து ப்ராப்பர் பர்மிஷன் வாங்கணும். ஓகே, ஸோ நம்ம கண்ட்ரி மாதிரியான கண்ட்ரில வந்து டிஃப்ரெண்ட் லாங்குவேஜஸ் இருக்கு இல்லைங்களா, அந்த மாதிரி கண்ட்ரிக்கு வந்து ஒன்ஸ் யூ ஹேவ் டு கோ ஃபார் காமன் லாங்குவேஜ் ஒன்லி. அப்ப அது என்ன காமன் லாங்குவேஜ், அதுக்கப்புறம் நம்ம கண்ட்ரிக்கு ஏத்த மாதிரி அந்த டொமைன்ஸ் எல்லாத்தையுமே வந்து எக்ஸ்பர்ட்ஸ் வச்சு ஹை லெவல் ஆஃப் எக்ஸ்பர்ட்ஸ் வச்சுட்டு யூ ஆர் சப்போஸ் டு கோ ஃபார் வாட் இஸ் இட் ஸ்டாண்டர்டைசிங் த டூல், ஸ்டாண்டர்டைசிங், ரிவியூவிங். ஓகே, அதுக்கப்புறம் அந்த டிசைன் பண்ண புது டூல வந்து we should confirm the psychometric properties. எந்த அளவுக்கு அந்த டூலுக்கான வேலிடிட்டி வந்திருக்கு, reliability, inter-rater reliability also we are supposed to check. And one more very important thing is internal consistency, compass also we should check it. அதெல்லாம் பண்ணி முடிச்சு வேல்யூஸ் எல்லாம் ரொம்ப சாட்டிஸ்ஃபேக்டரியா வந்திருக்கு.
சார் இதே மாதிரி சார் சம் ஸ்கேல்ஸ் வந்து நம்ம கோரிலேஷன் எஃபிஷியன்சில எடுக்க முடியுமா?
அதான் சொல்லுது, இந்த இதுல வந்து கோரிலேஷன் வேல்யூஸ் மூலமா தான் நீங்க கண்டுபிடிக்க முடியும். அந்த மாதிரி ஹை லெவல் ஆஃப் வேல்யூஸ் வந்ததுனா தான் நீங்க கேட்ட அந்த क्वेश्चनக்கு ஆன்சர் சொல்லி முடிக்கல. ஆக்சுவலா அந்த மாதிரி பெட்டரா உங்களால ப்ரூவ் பண்ண முடிஞ்சது, அந்த மாதிரி சூப்பரான ஒரு டூல் உங்களால டிசைன் பண்ண முடிஞ்சதுன்னா that tool could be implemented. And of course that particular tool we could use for different type of study designs. Explorative study designs இல்ல, தாராளமா correlative study design கோ இல்ல ஒரு what is it non parametric study designs கோ தாராளமா நீங்க யூஸ் பண்ணலாம்.
Sir, pediatrics available.
Pardon sir?
Pediatrics available. They are available. Pediatric cases.
Sir, quality of life அப்படின்னு வரும்போது pediatric population நான் சொன்னது டிஃபரெண்ட் இருக்கு இல்லைங்களா, அப்ப அதெல்லாம் வந்து எப்படி அப்ளை ஆகும்? So it will be entirely different.
Okay.
What is it? இப்போ pediatric patient தான் ஒரு 3 years baby pediatricல தான் வரும், ஒரு 8 years child pediatricல தான் வரும் இல்லைங்களா. 3 years babyல போயிட்டு இப்போ அவங்க கிட்ட என்ன கொஸ்டின் நீங்க கேட்க முடியும்? அப்போ மதர் கிட்ட தான் கேட்கலாம். மதர் கிட்ட பேபி பத்தினா குவாலிட்டி ஆஃப் லைஃப் அசஸ்மெண்ட் போற மாதிரி என்ன டூல்ஸ் தான் செலக்ட் பண்ணுங்க. அப்போ நீங்க அதுக்கேற்ற மாதிரி யூ ஆர் சப்போஸ் டு செலக்ட் தி டூல். அதுக்கு ஒரு சைல்டு போகும்போது டொமைன்ஸ் பாத்தீங்கன்னா என்விரான்மெண்ட் பாத்தீங்கன்னா நம்பர் 1 இஸ் ஃபார் வாட் இஸ் இட், ஒன்னு ஹோம், இன்னொன்னு பாத்தீங்கன்னா அவரோட ஸ்கூல் இல்லைங்களா, எஜுகேஷனல் ஆஸ்பெக்ட்ஸ். இப்போ இந்த ரெண்டு மேஜர் ரைட்ஸ் தான் வரும். அதை மட்டும் அதிகமா கவர் பண்ற மாதிரியான டூல் செலக்ட் பண்ணிக்கிறது பெட்டர். பீடியாட்ரிக் நீங்க போறீங்க, we apply our knowledge, to apply our knowledge நிறைய இருக்கு.
Okay sir. Yeah, clinical purpose. Sir, my name is Pratik Prem.
Okay sir. Yeah, வேற ஏதோ உள்ள क्वेश्चन கேட்க வந்தீங்க?
சார் ஆக்சுவலா கிளினிக்கல் பர்பஸ்ல நான் ட்ரை பண்ண வரைக்கும் நிறைய ஸ்ட்ரோக் கேசஸ்க்கு வந்து சில கொஸ்டினர்ஸ் வந்து அவங்க ஆல்ரெடி ஃபேர் மேடம் சார், நான் மறுபடியும் மேற்கொண்டு பேசுறப்ப அவங்க டென்ஷன் தான், நான் ரியாப்ப கொண்டு வரது ரொம்ப கஷ்டமா இருக்கு.
அதனாலதான் என்ன ஸ்டேஜ்ல நீங்க அசஸ் பண்றீங்கன்றது ஃபர்ஸ்ட் வந்து யூ ஷுட் டெவலப் a good very good rapport with the patient. தேவையான அளவுக்கு ரெஸ்ட் கொடுக்கணும். நல்லா நீங்க rapport டெவலப் பண்ணிட்டீங்க அப்படின்னா you could go on. இல்லன்னா WHO எப்படி 100% கேக்குறதுக்கு அலோவ் பண்ணுவாங்க? எத்திக்கல் கன்சிடரேஷன்லாம் ஃபுல்லா கன்சிடர் பண்ணிட்டு தான் அந்த மாதிரி டிசைனை வந்து ரிலீஸ் பண்ணிருப்பாங்க இல்லைங்களா. சோ அப்போ நம்ம வந்து எப்படி அந்த டூல டீல் பண்றோம்ன்றதுல நம்மளோட எக்ஸ்பர்டிஸ் அந்த எக்ஸ்பீரியன்ஸ் வெரி மச் இம்பார்ட்டன்ட். சோ தேவையான கேப் கொடுக்கறது, அந்த பேஷனுக்கு அதை புரிய வைக்கிறது, என்ன பர்பஸ்க்கான இது பண்றோம்ன்றத அவருக்கு புரிய வச்சிடும். இன்னும் ஒன்ஸ் அகேன் நம்ம வந்து ஹாஸ்பிட்டல் செட்டப்ல நம்ம பாக்குற பிசியோதெரபிஸ்ட் நம்ம டீல் பண்றது எல்லாமே வந்து அக்யூட் ஸ்டேஜ் ஆஃப் பேஷன்ஸ் தான். ஒரு 7 days to 10 days தான் நம்ம பாக்குறோம் இல்லைங்களா. ஒன்ஸ் அதுக்கப்புறம் ரிசல்ட் ஆயிட்டாங்கன்னா வாட் இஸ் இட், அந்த 7 days to 10 daysக்குள்ள இங்க மென்ஷன் பண்ணிருக்க கொஸ்டின்ஸ் எல்லாம் நம்மளால அசஸ் பண்ண முடியாது. மோஸ்ட் ஆஃப் தி டைம் குவாலிட்டி ஆஃப் லைஃப் ஃபுல்லா அசஸ் பண்ண முடியாது. சோ சம்வட் ஒரு பெட்டர் ரெக்கவரி ஸ்டேஜ்க்கு வந்ததுக்கு அப்புறம் தான், பிரண்ட் ஸ்ட்ரோக் ரெக்கவரி ஸ்டேஜ் ஒரு 2 or 3 வரும்போது தான் மோஸ்ட் ஆஃப் த குவாலிட்டி ஆஃப் லைஃப் அசஸ்மெண்ட் டூல்ஸ் நம்மளால இம்ப்ளிமெண்ட் பண்ணவே முடியும், எஸ்பெஷலி இன் கண்ட்ரி லைக் இந்தியா. உண்மை, நம்ம ஒத்துக்க வேண்டிய உண்மை. நம்ம பாக்குற அந்த இன்ஸ்டிடியூட் பேஸ்ட் ரீஹாபிலிட்டேஷன் வெரி அக்யூட் ஸ்டேஜ்ல வந்து எல்லாருக்குமே அந்த நீங்க உங்களுக்கு மட்டும் இல்ல, எல்லாருக்குமே அந்த ப்ராக்டிகல் இருக்கதான் செய்யும்.
ஓகே
எஸ் சார். எனி அதர் பர்சன்ஸ் having any doubts? I think the time are.
சார், தேங்க்ஸ் ஃபார் கிளாரிஃபைங் சார். தேங்க்யூ.
Thank you, sir. Anybody else like to?
Sir, good afternoon, sir.
Good afternoon, ma'am.
Actually, I have done MPT in my obstetrics and gynecology. Sir, இது வந்து கொஞ்சம் unrelated
Audience
question.
participants, any other questions? You can
One of the
post
slides
as
is
well,
asking
audience.
question, ma'am. Yes, madam. Yes,
Yes,
madam.
Actually, the bladder and bowel dysfunction.
We are having a very good interactive session. So, participants, if you have any questions, please post.
Yes, sir. Sure.
Okay.
So, bladder bowel dysfunction வந்து ஏதாவது ஸ்கேன் இப்போ லேட்டஸ்டா இருக்காங்க சார்.
Ma'am, actually, what you are asking is one of the function in our body, madam.
Yes,
So, நான் என்னோட domain to discuss the FTP is quality of life measures அப்படின்னா So, நீங்க கேக்குறது எதுல வரும்னா பேசிக் ஆக்டிவிட்டிஸ் ஆஃப் டெய்லி லிவிங் அசஸ்மெண்ட் டூல்ஸ் அப்படிங்கிறதுல வரும்.
Yes, sir.
சரிங்களா? So we have a lot of tools. அதுல எல்லாம் பாத்தீங்கன்னா இந்த பர்టిక్యులர் bladder and bowel related problem அதுல அந்த ப்ராப்ளம் அசஸ் பண்றதுக்கு அந்த இதுல ஸ்பெசிபிக் டொமைன்ஸ் இருக்கும். We will be chart அதெல்லாம் பாத்தீங்கன்னா இருக்கும். இது வந்து என்னோட நான் இன்னைக்கு டிஸ்கஸ் பண்ண அந்த பர்టిక్యులர் what is it the knowledge content out of வருது. நீங்க வேணா பர்சனலா கான்டாக்ட் பண்ணுங்க. I will actually the times are with this I just conclude and thank you everyone for the conducting authority and the audience, each and everyone for listening to my class. Thank you so much.
Sarveshwaran sir, you got a question in chat box. Please go through that question. There is a question in the chat box. So the question is, I think Ms. Nirmala Devi has asked you about limb dominance, quality of life. With that, you said you should consider whole body as meaningful. How is it possible?
Quality of life it is. Ma'am, the question get a person name, madam?
Ms. Nirmala.
Yeah, Nirmala madam. குவாலிட்டி ஆஃப் லைஃப் அப்படின்னு நீங்க வந்துட்டீங்கனாலே நம்ம என்ன பார்க்கிறோம் அப்படின்னா அஃபெக்டட் சைடு மட்டும் தான் நம்ம பார்க்கிறோம். ஸோ ஆக்சுவலி saying like affected stroke patientsல affected side there is more affected side and less affected side. அப்போ full body quality of life வரும்போது full body தான் வரும் ஆக்சுவலா. ஒரு ஒரு பர்టిక్యులர் சப்அக்யூட் ஸ்டேஜ் தாண்டி பேஷண்ட் ரெக்கவரி ஸ்டேஜ் வர்ற பட்சத்துல how far the patient is contributing is more affected side to accomplish specific level of quality of life. அவரோட more affected side எந்த அளவுக்கு யூஸ் பண்றாரு, less affected side எந்த அளவுக்கு யூஸ் பண்றாரு அப்படிங்கிறது வந்து தனித்தனியா நீங்க அந்த அந்த டைம் பீரியட்ல வந்து டிஃபரன்ஷியேட் பண்ணி பார்க்கும்போதுனா we could get it. But actually quality of life என்ன அசஸ்மென்ட் பண்ணும்போது டாமினன்ட் சைடு நான் டாமினன்ட் சைடுன்றது பார்க்கிறது கரெக்டா வராது. motor functions போலாம். ஏன்னா you could say like what is speech functions. ஏன்னா டாமினன்ட் ஹெமிஸ்பியர்ல தான் ஸ்பீச் ஏரியாஸ் இருக்கு இல்லீங்களா? அப்ப ஸ்பீச் ஃபங்க்ஷன்ஸ்க்குலாம் டாமினன்ட் ஹெமிஸ்பியர் ஃபார்ம் பண்ண நான் டாமினன்ட் ஹியர் நாட் we could say or a problem called unilateral neglect. அது மாதிரி ஸ்பெசிபிக் ப்ராப்ளம்ஸ் போகும்போது இப்போ go on with that dominant cell involvement or not dominant பண்றதெல்லாம் more applicable. But quality of life னு போகும்போது not a good இருக்கும். ஏன்னா நம்ம இங்க ஓவரால் லைஃப் ஆஃப் த பேஷண்ட் அதுவும் குவாலிட்டி ஆஃப் லைஃப் ஆஃப் த பேஷண்ட் எப்படி பட் ஆனா போகணும்னு நினைச்சா அப் டு த இண்டிவிஜுவல் பர்சன்ஸ் எய்ம் அண்ட் அப்ஜெக்டிவ்.
Yes, thank you, sir. Thank you so much. It was a very good interactive session. So I think if you are still presenting, could you please stop presenting, sir? So that the next person can set the pace. Yeah.
Okay, ma'am. Thank you. Thank you for everyone.
Yeah, and I would request Mr. Alexander to take over. Yeah.
Yeah, thank you.
I think you have got one more question. You can stop presenting, sir. so that the next session will be, they'll be setting the pace for the next session. Meanwhile, Salvation sir, you got a question in the chat box. Could you please look into the chat box? The question is, can you suggest any bladder and bowel dysfunction assessment scales? I think you answered already. The answer is in quality of life. Most of the quality of life scales have all the components. Yeah.
Coming under motor functions and not quality of life.
And I think, sir,
it will come with quality of life also, certainly it will come. But in our assessment tools, that particular function, when you take, it will come on our motor function scale. Already I answered.
Yes, sir. Thank you so much. I think we can set the pace for the next session. Thank you, sir.
Okay, ma'am.
Thank you, Mr. Selveshwaran sir. Thank you for your insightful and impressive talk on quality of life. Thank you, participants. And one more instructions for you all. I think we are having an audiences from other part of India, so that please, while asking questions, maintain in English language, so that other participants also can understand it. Okay, now we'll move on to the next session.
Good afternoon to all the participants. We are moving to the second session of today's FTP program. It is my great pleasure to invite our next speaker, Mr. Magendran sir, MSc Medical Anatomy, Associate Professor, KMCH College of Physiotherapy, who has 10 years of experience in clinicals and academics. We invite you sir, to give a talk about outcome measures for pain. The floor is yours, sir. That's it. Oh, okay.
Hello.
Excuse me, there is a background noise that is running here. Can you type in the chat box? This is it audible background. Hello? Yes, audio is clear. Thank you. Okay. So, my topic is the outcome measure for the pain. So, pain is a symptom, a sign. It is a symptom. You know that everybody will know that it's a symptom. It's dealt by the patient. So, it's a normal definition. Don't find it anything in the physical practice. No sign. So, it's a symptom. So, pain is as simple as that. It's a symptom. So, we going to identify the value that is a key consideration of the selecting goal. So there are some pain outcome measures tool available, but how to choose it? For that, we need to understand the reliability. But that means the tool is able to produce a consistent result, and validity, the tool is able to accurately measure the pain. The responsiveness, that means the tool is able to detect the change in pain over the period of time. Then clinical utility, the tool practicality and easy to use in the clinic. So these are the things before you need to consider when you're selecting the tool. But how many tools are there? There are going to be broadly classified into two types. That means the type of outcome measure being going to be classified into two broad categories. One is a biomarker, other one is a clinical outcome measure. Being a clinician, I'm going to be talking about the second category, that is a clinical outcome tool. But though I'm going to touch a little bit upon the biomarker aspect. So basically, two types of outcome measures are measuring tools available. One is a biomarker, other one is a clinical outcome assessment. So what is a biomarker? The molecular biomarker means these are the biological molecules which found in the urine sample or blood or tissue that is going to be reflective of pain mechanism. In case of myofascial syndrome or maybe a chronic osteoarthritis, so you found the check the blood marker that those people that two molecules spectral alpha is increased and the site of actin like interleukin 6 is increased, C-reactive protein is increased. So everything is going to be increased. So it's that we can identify the intensity of the pain intensity going to be increased. That is how the going to be the quality of life is also decreased further. So this is one of the implement marker we see that the pain thing we can identify. Other one is a neuroimaging biomarker they can use, functional MRI they can use, emission tomography they can use, electroencephalography they can use as a recording image, and physiological biomarker in which what they going to do means the electrochemical skin conductions. That means the measure the sweat gland activity. This will be they going to be measured mainly for the nerve processing the autonomic nervous system response to the pain. Say for autonomic mainly the thing is pseudomotor and the vasomotor. Pseudomotor means what is the certain is also known as pseudoreperissement. So here they are going to measure the pseudoreperissent gland activity, so that is useful to diagnose for the small fiber neuropathy associated with the neuropathic pain. And there is a one device like this, a nocimeter, that is going to be analyzing the pupil size in response to the pain stimuli. So that with that they can understand it. They're going to identify the pain response. So these are some basic biological marker with with that they can identify the pain and outcome to consider as a pain outcome. And coming further, as a physiotherapist, we should understand at least this is the very main motto, that is a clinical outcome measure, is very important. I think so. So what are the things? This is going to be some broad classified into some category. So what are the some categories are there? So the pain reported, that means this so many variants available. What are the subclasses are? The patient reported outcome measure, the clinician reported outcome measure, observer reported outcome measure, performance outcome measure, and digital outcome measures are there. So, see, everything we cannot going to be covered in this one within our 1 hour. So, what I want to do is like throw some light on one give you an example of the patient thing, one example for the clinician thing, one example for this one, so and so. Right? So, although this is we can use it as a biomarker, or we can use it as a sophisticated tool like this patient report thing, clinician report thing, anything we are using also. There should be always possible error can be found, because the pain is a subjective thing. You cannot properly you cannot maintain it, measure it. It's very difficult to do that. So for that, I'm giving you some basic ideology about understanding the pain. Then I'm going to be talking about all these things. So give me a 5 minutes time for the understanding about the pain. Then not understanding about the pain, so I'm going to talk about some of the factors which are going to be influence the pain. Then I come back to the state. So for example, let's take the low back pain as a consider one patient. So one patient came to me. She's a 40-year-old woman. It's a fitness enthusiast. She visited my clinic for the back pain reason. Right? She has a 15 years of experience of daily on today daily going for the gym every day. Is going to be she's going to be getting a week gym, right? So she never skipped the gym even in the busy days. So however, one fine day, she's doing a deadlift. That time she got a piercing pain at the lower back. She's not this is a momentary. The pain is a little bit of momentary. She continues to do that exercise, the gym, but it's not going to be reduced. So that now pain is more intensified. So bending forward itself has become more painful. So for that reason, she came to me this way. On the time of examination, I'm asking the question, but before she's asking me, on the time of examination itself, she's asking, why it's so painful, doctor? The pain. Is it a dispulse like my spouse have? My spouse has. That means she have already experienced, he heard, he had experience like in some back pain, or her spouse. Right? So how long it will be take to resume my normal life? Can I still go to the gym? So fear factor is there. It's possible to do that. So fear factor is there. It's common influences. Will it able to do that deadlift is in the future? Is the back pain is never posed? What will I do? So she's have some different opinion regarding that. So will I still be able to do the deadlifts or activities like in a home very earlier before it's possible? And since finally she told that, please do not this condition my situation to my husband, because she will be scared about this thing. So just tell him, just cough muscle space. Cough muscle space. Even if you told, he won't allow me to enter into the gym. So please don't tell him. So I give you one case scenario. From the case scenario, what did you learn at the from the example? The patient has looked at this, the second point that finds how long is going to be interesting in my life. See, can I still go to the gym, able to do the deadlift in future? So he has a future thinking is happening. And she's having a past experience. And she's having a the fear factor is there. So everything changing the small pain, changing the alter the behavior of the patient. So that this is what I want to mention in your mind. This is psychological components also. That is why it's very difficult to quantify the pain. So the cultural factors. So this was one more factor how the culture can be influenced the pain. The study conducted by the Sharma et al. On the neighbor, and the neighbor is connected to the neighbor. What they could determine is the prevalence of the muscles and the pain in the neighbor. What they found it in many people. In the rural people, rural labor, they did not report their low back pain, because they assumed it as a normal nature of aging process. As a result, an employees in the rural village, they tend to continue to carry their without seeking any medical attention or medical treatment. But in contrast, the urban Nepalis believe that the back pain is caused by some thread tissue, something danger in the tissue, something damage in the tissue. So they try to seek the medical attention or medical treatment. In Western countries, the people are going to be publicly express their pain and seek the medical attention. The Western people culture, they had some injury, they immediately talk to the public. Publicly, they tell they're going to be express the pain, so they seek the medical attention. In German country, everybody we know that they're known for the productivity and efficiency. So they won't tell the pain as like the Western. So coming to the Indian culture, what if that's a little bit of thing here? See, you look at the picture, first one is ear piercings happening, the body piercings happening. Some people are walking in what's the fire what they call it as. That time the tissues are actually damaging here, but they won't feel pain. Why it maybe is because the reason can be the spiritual motivation. At the time they're doing the chanting, they're going to be the music, the good music, the spiritual motivation, the love to the God, they're going to be reduce the pain, and they produce the endorphin is going to secret in this body. The communities about the family, friends, everybody's doing that. So that is how they feel little pain or no pain at all. So this is how the culture is going to be influence the back pain. So let's come for the personal belief. So I took the one more case studies over here. The Fisher et al. Shows that one construction site, the person actually accidentally leave their feet on the 7-inch nail. You see that in the first picture. So this is the area. So if they leave their feet on the 7-inch nail, that and that. So after seeing that, the person is crying like anything, the excruciating pain is there. Assume that. So the person is admitted to the emergency casualty room where he can't tolerate any other pain. So they could be administered with anesthetic agent, so medicine. After giving everything, they cut and remove this wound. Then they found it. Actually, the nail is not into the tissue. It's passing between two toes. So here, the person is a false beliefs making an excruciating pain. There's actually there is no damage in this. The nail is passing between the great toe and the other. The second, so no tissue damage, but person is pain experiences a much severe pain. But coming to the second case, the same thing is happening in the construction site. The person is accidentally the nail gun using to playing with the nail gun, so they got accidentally punctured into the nose. So the nail is getting to the same, right? So, but the person is actively damaged, but the person is unaware of it. There's no pain at all for him. After 5-6 days later, he got a tooth pain. For that, he went for a medical department. Then they found it as a nail is there, and they removed it. So here, tissue damage is there, but actually the person is no pain. No, person is not feeling the pain. But here, the tissue damage is not there, but person feeling the excruciating pain. So this is a personal belief. How the personal belief can be influence the pain also. That is why it's very difficult to getting an outcome to the pain is, I think, a little bit of right. Yeah. Then next point is myths. What are the myths? Some patient come to me as a clinic. So what they tell that I purchased orthopedic matters. Still, my back pain is not getting better. That means they say that I purchased 40,000 rupees, 50,000 rupees of mattress set that, but still my back pain is not there. That is about the myth. And walking more than 30 minutes induce my pain. That is a headache. After that, because before 30 minutes, I'm not getting any pain. But after 30 minutes, I'm getting a headache later. Some people tell that walking regularly reduces my knee pain. But if I discontinue, it is again come back. So then, both patient they tell that I used to hit the gym every day, but when I stop, I get my pain is back. Fifth patient is telling that I got a back pain due to the after getting a epidural injection. After on the side of the epidural injection, only I got a pain. Patient 6 is telling that after having my uterus hysterectomy, that is the point where I start experiencing the back pain. So these are the examples of how the patient myths, their false belief can be affecting the pain. But the not be a case of the actual reason of the pain. So like that, the gender, yeah, affecting the pain. Genetic things are affecting the pain. Age affecting the pain. Yeah, when the age advances, the pain sensitivity is going to be decreased. In case of genetics, say for example, some people having a SCN9A, that is a gene is there, this get mutated. The what happened to this patient? Those who are having the mutated gene, this gene, they leads to increased pain sensitivity. The small step also having experiencing pain. So what I'm telling here is, it is a all about psychological, biological, and social. So the pain having a multifactorial thing. When sleep is required, proper sleep is required, everything is having. So by definition, what's the pain is that, so good definition is by the International Association of the Study of the Pain. They tell that as an unpleasant sensory and emotional experience arising from actual or potential tissue damage, or it described in terms of a such damage. Is that so? This is about the pain definition. So what I'm telling is the pain is so subjective. So measuring is so very difficult to measure. But still, nothing is better than, as usually we call this, nothing is better than, excuse me. So pain is subjective. So we need to measure somehow. So what are some clinical outcome measures we can do that? So initially I told you the biomarker we done it. So the physiotherapist point of view, the clinician point of view, we should know this is a thing. So patient reported outcome, clinician reported measurement, clinician reported measures, and observer reported outcome measures, performance outcome measures, and digital measures can be used. So I give you one example from the each thing, and we'll try. So out of this thing, which one is the hierarchy model? Hierarchy is the other thing. I told the pain is symptom is dealt by the patient. So hierarchy is main thing is patient reported or commission. So we go with that, stick with this because this is having a higher validity, higher reliability, higher indirect reliability, indirect reliability. It's mainly focused from this area. So we have to focus on that thing. So that's what the studies also told that attempt to elicit the self-reported thing, self-reported of pain from the patient. Okay. So the clinical outcome, first thing I'm going to talk about is pain reported outcome, patient reported outcome measure. There are everybody knows that it's a unit in that that category is that the unidimensional thing is there, multidimensional thing is there. So I'm giving you some examples of unidimensional thing. So one other thing is visual analysis scale is there. What to be 10 centimeter wide, 10 mm thing. To line one end of the line is having no pain, other end is having possible pain is there. So ask the patient to do that marking over the entire sense of pain is there. So that's how we do that. And this modified version of this thing is to be a numerical scale, numerical pain rating scale is there, and face rating scale is there, and verbal rating scale is there. These are the examples of your mono dimensional tool or contour. So let's talk about the VAS scale. As well as originally is developed from the 1921 start WA. It's the first person to use this thing. Then later it's a 1969 application CB. He validated and expanded the use of in clinical psychology. So VAS scale, the content validity is high. Directly measures the intensity of the continuous because in the continuous scale is there. Then construct validity is a supported thing. Strong correlation with other scales. The criterion validity is also so good. So response coming to the response if the sensitivity change is so high. Pascal is sensitive to small changes in the feelings. So making that preferred tool for the clinician for the detecting the effects. So small change in this area, so we can address as a valuable tool to consider whether the person is getting improved or not. So reliability, test reliability is high. The interrelated reliability is also high. So that feasibility is yes. It's easy to use. It's a simple and quick administrative. Do not require any virtual or numerical literacy. Making it suitable for almost all the diverse population. The limitation is there. It may be difficult for some people. Those who are elderly with visual or cognitive or younger children, it's very difficult to understand this thing. So these are the limitations there. So basically, the summary of the VAS scale is vulnerability is high, constructivity is strong, test reliability is high, Internet reliability is high, responsive is high, feasibility is also high. So let's come to the NPR scale. The NPR scale is a technical scale, it's another category scale, which is how it's developed. It's developed from that the VRS and visual analytics. So modification evolved from these two scales. We got the NPR scale. So it's used in the clinical setting from the 1970s, from the 1970s to 1980s. It's very simple to just quantify the subjective pain experience, track the change in pain over the period of time in response to treatment, whether it's a change. Let's say the person is 0 is no pain, 110 is a maximum pain. The person is saying first day, they score is a 5. You've given a treatment. After that, she's saying the pain is reduced to level 2. So you are going to be track the changes of your pain level. So it's going to be facilitate the communication between the patient and the clinician. So how to administer it? We know that on the scale of 0 to 10, how will we rate your pain at right now? So there are so many variables that we can use for the acute pain, we can use for the chronic pain. So interpretation, how will we going to interpret this? 0 is a no pain, 1 to 3 is a mild pain, 4 to 6 is a moderate pain, 7 to 10 is a severe pain. So minimally clinically important difference. What that means? The change of the 2 points at least, that is we consider as a 30%. Right? So typically consider a meaningful change in clinical setting. So if you before pre-test has to be 10 months score. Let's take the example of pre-test pain is pain score is pain is 5. After you have given a treatment, pain is going to be reduced to 30%. Means is considered as a meaningful. Your treatment is worth. Then coming to the psychometric property, the NPR scale is again cognitive validity is high, construct validity is strong, criterion validity is so good, test rate test reliability is also high, and responsive is also high. Feasibility is very high. Right. Coming to the multi-dimensional scale, this should be explained by the Dr. Prakash in upcoming workshops. So we'll skip it. So like that, so many things are there. I talk about we covered it. First one's a patient report outcome could be done. So here I told second coming to the second one, the clinician reported outcome. So those are I'm giving one examples for this area. So the scale is a PAC scale. So what is the stands for? F for face, L for legs, A for activity, C for triangle, C for another C for console. So PAC scale is an observational tool. That means this used to pain in non-verbal patient, especially those who can't express pain properly. Say for example, infant, young children, especially from the age from 2 months to 7 years, they can't tell their pain. Individuals who are non-communicators, say for example, cognitive impairment patient, a sedated patient, critically ill patient, they can't tell their pain properly. So each of this 5 category is scored from 0 to I show the slides 0 to 2. That is the total score is 0 to 10. So let's say that score breakdown of that means the face, they see that observer, they have to see that. See the 0 means no particular expression as smile. That means who's giving a score is 0. Occasional frowning, disinterested, so you're giving a score number is score 2, score is a 1. Then frequent constant frowning. So clenched jaw like that, so if you see that means something right, you can express as a 2. So like that, finally you have to give a total for each face, leg activity, cry, consolability. We do that means so 0 means relaxed and comfortable patient. So 1 to 3 means the patient is in discomfort. 4 to 6 which indicates moderate pain. 7 to 8 which indicates severe discomfort of the pain. So for the target population mainly we already previously mentioned it one more time. So who's going to be applied for this admission for this, especially for the infant toddler who wants to 7 years and post-operative children who non-verbal patients, developmentally delayed children, adult intensive care patients, or patient in a ICU unit, and the patient under the sedation and intubation can use utilize it. So this scale is again the content validity is also high because it is designed by the expert pediatrician. Construct validity is strong because the other scales like names, right? Criterion validity is good. Reliability is a higher reliability. So intelligence is also good. The responsive is also good. Feasibility is also easy to use. I'm quick to administer less than 1 minute. So it's a good tool to use it. So we covered it, patient outcome report, patient outcome measure, then clinician outcome measure, we done it. Then, if this not possible, the other one is observer outcome measures. What is observer outcome measurements? We'll talk about that. So, yeah, we came. So, this is one of the type of clinical outcome, which is in which what happens? The third party, that means a typical caregiver, our parent, our teacher, clinician, who going to be report the observer sign, behavior, or even related to the patient condition. So, it usually is used for who when the patients cannot self. The patients cannot self-report it. We can utilize this tool as observer reported outcome. It's not based on the subjective interpretation of the symptoms. Okay. So when can be used for those who are patient who cannot reliably and self-report, we can utilize for this tool. The target population of this thing, we examples, because so many tools are there. This one of the tool we already told. Summary, basically what it's measured is observable signs like behavior. So we are asking question to them. What are the questions we asking the reporting to them? Your child is crying more easily than usual. Is a play less than usual. So you're asking yes or no question. From that, you're getting analyzing some report. You get it, run the knowledge, run all the collected information in your mind and run the knowledge towards this area. You get to know that what is happening for them. So this is a summary about what is measured observer sign or behavior. Who reported is caregiver, teacher, clinician. Target population is none of those are not self-reported points. Psychometric is actually the psychometric scale is validity is less. So we need to do that psychometric needs validity, reliability, responsiveness are needed. It's not suitable for internal states of mood or pain intensity is not related for that. So, but it is accepted by FDA recently. So this is about the clinician outcome measure we done and observer outcome measure we done. The last one is before last is performance outcome measure. What is a performance measure? This is not exact clinical tool, but from that we can give an example. So given a patient is a 6-minute walk test, we know that we choose 100 meter, 100 meter, from that at least 25 meters, then this should be that patient has to be fixes a starting point and end point. We ask them to walk in a normal speed, above the normal speed, that means brisk walking has to be done. So those things should be done. The patient is walking, stay comfortably for 6 minutes. If in between they need a break, means we have a chair, we're going to be ask them to how many minutes they're going to take rest. So everything we had some validity. We already validated. We mark for the age groups, for men is different, for women is different, because the balance is different. We have to put it. So we already have pre-reported record. So you do the time the test and try to get a result. But why the performance of the measures here are going to increase? Because the pain is there if the person cannot complete the thing. So that's what we going to be done. So another example is a 6-minute text. We're trying to do that. Means what happens? The 6-minute text you are asking how far the person can walk within a time. They're expecting that someone is significant pain, more limited distance as to compare the person who does not have any pain. So those are the pain. It's very difficult to complete the 6-minute thing without pain. So it can be used as an outcome tool as well. So usually this outcome tool is going to be under the observation of the assistant or staff member is going to be administered with this. The clinical tool, we've done it so many things. The last one is a digital ergometer. I'll show some video to that. What is a digital ergometer? Second. So see that there's a video which shows that we need to quantify the pain. How they're going to be quantified? Means use this. Yeah. So I'll show one more thing. Another thing is, see, there's a painful point is there. You're going to be applying that instrument. The instrument is going to be a pain ergometer. Sometimes they're going to be used as a dolorimeter as well, but dolorimeter, the interchangeably used, but dolorimeter is totally different. Principal philosophy is another one. Same thing. Excuse me. So the last one is you need to quantify it by digitally by means of pain ergometer. So we can, there's another thing they call as dolorimeter, but in the dolorimeter they can use assess the temperature. We can assess the temperature including heat, cold, it's warm, those things we take to be identified. But this is for purely for the pain. But actually that is historically very old dolorimeter. Pain ergometer is a reason. It's nothing but their software is program that the pressure is coming inserted in that area. You're going to be applying the instrument with the pressure of pressure tissue. In that, what happens? The pressure turns into the pain. That time the patient has to be reported. That time you need to is recording the on value. So you have to do that for 3 to 4 times. Take an average of 1. So that should be the patient pain response. So now this we need to quantify the pain outcome as a thing. So what are the psychometric properties of the type of things? Interreliability, everything is excellent and good to excellent. Test resistance is also good. Consider this is supported as the essential to the defense. Criteria is also wanted to start. The response want to start. Apart from that, so see, these are the so many good tools are available for neurological science, so many tools are available. Conditional musculoskeletal, so many tools are available. Whatever you want, specific patient reported this pain, just type it in a Google, you get the scale. It's going to be easily applied on this pediatric population. There's different scales are there. Like you said, there's different scales are there. Chronic scales, cardiac conditions, different scales types are there. Peripheral vasculitis, sometimes are there. ICU, unconscious patient can be used as different scales there. So this is how we need to assess that. So this is like the eye-opening tool that so many tools are available for the pain. Especially we talk about musculoskeletal point of view. So far, last 1 week you learn from neurological scale from the spectrums. So next week onwards we will be getting a scale multiple or combined the musculoskeletal conditions which is coming up. So with that I will finish my talk. Do you have any questions, participants?
Yeah, I have, sir.
Yeah, yes, ma'am.
Sir, I have one doubt. Don't mistake me.
Yeah.
Recently, we are just using scales for research and clinical applications. Is it reliable in reality life or not, sir?
Sorry, ma'am, I couldn't hear. Can you repeat one more time? Or else you type it. Let's see that.
Sir, I have just. Sir, is our research scale and our clinical application scales are reliable in real life scale, in real life applications?
So in terms of what condition you're asking? See, it's to
our conditions, sir. Mixed populations.
In mixed populations, okay, man. But the thing is, when coming to the pain category, what you have to do is, I told you in a very earlier. So you need to consider all these factors. The pain is a subjective. You cannot fix it as even though you are using some clinical thing, but this one, what you told is a patient reported thing. So it's very related to have a. We believe that okay, so far this is good. We go with that. So can you type your question once again? Because I can't seriously, I couldn't get to your question first.
Sir, one sec.
Anybody have any other questions out there? Yeah, this can you show you again? Yeah, those things will going to be explained in upcoming lectures by the orthopedic department. So I'm just showing that some scales. What I will show you. Share it.
Sir, I just posted the question in chat box.
Yeah, yes. Your question is a clinical scale. Is clinical scale and research scale based on research based skills are available in real life application? It is not possible. You know that some skills because there is a complexity there. But you are talking about for what that. So you are saying clinical scales and research based scales are reliable in real life applications means some it always shows some error will be there.
Sir, we can use in every aspect, or is there any limitations?
Everything, every scale having some limitations there as in person answer. Based on that,
Mahendran sir,
yes,
shall I explain, sir?
yeah, yes.
Because sir, good afternoon, sir. What Mahendran sir told is a low back pain is a multi-dimensional problem. It's not going to only one segment going to patient have. That means biological, psychological, and social. So we cannot expect every component in one scale. That will be very complicated one. It's not possible to everything comes in one scale, sir. That's why
Sir,
number of sets of questions are there. That's why they are going to use for different scales for different things. For pain means we can go with one scale. Or pain and the limitations and pain and quality means we go for some other scale. We cannot expect for everything in one area, especially for pain. What sir is telling repeatedly because of subjective. It's very difficult task because we can't confirm it whether it's really telling pain reduced or that things and all. That's why we are going for number of questions. That's why we are going for validity, reliability, responsiveness, and this many things we are sensitivity and specificity. For this many things we are go through it. According to that, what is your objective? What is your main objective? According to that, we can choose our scales.
okay. Sir, another thing, I recently tried to do my descriptive study about this. Is we can just show like clinical sales are reliable in real life, or research based skills are reliable in real life application. But some they are not accepting that you can't just say like research scale based questions, like research based scales are not reliable. They're not accepting that, sir. What can I do for that?
Please, if you give some examples, what you are meaning by clinical scales and research scale, please give me one example for that. According to that,
Sir,
we can
okay. Yesterday, ma'am explained about that demi scale, no, sir. That's a research based scale.
Yeah, excuse me. I'll just add up some information regarding this. Yesterday you were asking, like you wanted to use a scale which will cater to the needs of all population. So DEMI is a scale which is used for all the neurological populations because each population specific scale we can apply if you have a mixed group. Similarly, most of the pain scales the today's speaker has explained is applicable to all the populations. It is a generic scale. So the condition specific focused scales we have not explained today. Those will be explained in the upcoming sessions next week. Today, the scales which have been informed to you, like the general pain scale, NPS scale, and the algometry, everything, this is like you are understanding the quality and the quantifying the pain using the algometer, and you can use this for any population, people with pain. So whatever maybe it's like pain for a neurological, dysfunction person, or to a person with OA, or to a person with myofascial syndrome, or to fibromyalgia, or to a person with anybody who got pain, you can apply this.
Ma'am, can I do a descriptive study about this, like pain scales and pain research based scales reliable in real life application? Can I do that too?
Yeah, so you are stuck with this word real life application. So I just explained. See, most of the scales which has been developed by the researchers across the globe, they have developed in such a way that it is more reliable and valid and sensitive to pick up the changes, and it It's more applicable in, I mean, the real life in the sense like from the person perspective, it should be valid and sensitive enough. So the scales are developed in such a way only. But if you have a meaning, different meaning to the word real life setting, like what you're asking is real life setting in the sense somebody coming to your department with pain and there they rate your pain, that is different. And somebody in the real life, you're giving a kind of a telephone interview based scale, and from home they are rating their scale, that is different. So I think your routine NPS could be done. It is like a this could be used through various modes of application. You can do it like in presence, you can do in front of the patient. With presence, you can ask it qualitative, you can ask, or you can ask over the phone. So it is versatile. You can use it anyway.
Okay. Ma'am, if I am presenting a paper, can I show off the article which is based on this? Is it okay?
If you got doubts, please mail to us. I mean, you can mail. We have given you the mail ID, right? FDP KMCH PP. So if
Yes,
you want to discuss about your paper, please don't. I mean, don't hesitate. Please free to send your paper and put your questions, and we will review it and we will give you the feedback. And we can.
Ma'am, I
We can
recently
discuss what
did,
update we
ma'am,
can.
ma'am, I recently did my paper presentation based on exoskeleton in Tamil Nadu MGR University.
Okay.
We can publish that paper. I just did a literature review for that paper.
Yeah, so that depends upon your setting, like who guided you, and those based on those various things, you can go ahead. It depends what is the quality of your article and how well it suits the international standards and what kind of journals you are selecting. Based on that, you can take the next step. No harm in that, and you can, because that is the way you learn. So you will please go on with that. Yeah. So with more of trial and error, you will definitely come to one point that you will be a refined researcher.
Okay, ma'am. Thank you.
So participants, any more questions related to today's topic?
Yeah, Sami Duraisan asked question, aren't all clinical pain scales research based? Mahendran sir?
Yes, sir. So most of the things are research-based thing we've done it, but thing is, I told you, since it's a subjective thing, the age is affecting. Like, always come with some limitation. These skills are come with some limitation. Age is affecting, genetic is affecting, and, what is that? Culture is affecting, personal belief is affecting. So many factors are there. Along with that, we have to utilize our brain to do that as well.
Yes, sir.
And the Indian population is such different. So everything, the past experience about the pain is different. So everything is different. So the thing is, the clinician based skills are research based, well done. This is based on that's always come with some limitation.
Yes. Thank you, sir. Thank you.
Yes, please.
Yeah, if anybody having any questions, you can put in the chat box. Or
So
you can,
again, participants, we want to make sure that today's talk is more about the generic or the general pain measures which we use across all population. We have other category, that is neuropathic pain or neurogenic pain. So that we have not touched upon. We do have specific scales for neuropathic, especially post-diabetic neuropathic. We have fantastic assessment tools. And even for dysesthesias, post trigeminal neuralgia or post Bell's palsy, facial palsy, so many central pain syndromes, separate pain measures are there. Maybe you can dig into that and read more about that, or if you get any chance, we'll try to update later. Thank you.
okay, we can move into concluding the session. Thank you, Mahendran sir, for your inspiring talk. And thank you, participants, and for your impressive and interaction throughout the sessions until now. And hope we are expecting further next week sessions also. And as ma'am told, we provided feedback forms and post MCQs links in a chat box and as well as in a WhatsApp group. And please respond it so that we can proceed further on other things based on that. And we can expect in the weekend days for the week 2 pre-test link also, so that for week 2 pre-test link, please try to fill it before starting the next session. So next Monday we will be joining again afternoon 2 o'clock. Until that, you can see.
Yeah, so before closing, let me add another point. The chat box, please find the feedback form and post MCQ for week 1. And those participants here also, please inform your friends who are in this and those who watch the YouTube video also, a recorded YouTube video of this session. Participants, make sure that you respond to the post MCQ and the feedback form for week 1, which has been posted in the WhatsApp FTP group. Kindly note, everybody, the YouTube watchers video is uploaded and you'll be watching it at one point of time. So when you watch, please make sure that you go to the WhatsApp group and also complete the post test and the feedback form. So as we already said, to completion of the FDP, you need to have considerable amount of attendance as well as complete all these tests and feedback. Then only we'll be able to issue you the e-certificate. So that's the end of the week 1 program. So I thank all the speakers and the moderators and the committee members and faculty for success of week 1 program. So thank you everybody. Thank you so much. We will close this session. Thank you.
Thank you.
Thank you, ma'am. So requesting all the participants to leave. So it's a humble request. Participants can leave. We might be having some background check.
உள்ள பண்றாங்க ஒரு தடவை வெளியும் வர மாட்டேங்கிறாங்க.
சரி, YouTube